speaker of the morning session is Dr. Anna Miller. She is an associate professor and vice chair of the Department of Orthopedic Surgery and chief of orthopedic trauma at the Washington University School of Medicine. She has an interest in orthopedic trauma clinical outcomes research and function after orthopedic injury. Dr. Miller's research background includes anatomic studies and biomechanical evaluation of orthopedic trauma injuries and fixation, and she has extensive experience in working with and analyzing orthopedic data and large trauma registries. Welcome, Anna.
Thank you. So I know I'm keeping us from lunch, so I'll try to get through this. All right. So thank you for that introduction, and thank you for having me. Definitely have learned a lot and appreciated all the talks this morning. So hopefully orthopedics can show you some more confusion. I just wanted to say that I think it was Dr. Lay, I came in just a little bit late, mentioned that orthopods are more comfortable with sub-Q heparin. And I think that is a classic example of your training and your institution and what you're used to, because definitely some places feel that way still, even though sub-Q heparin is kind of ancient for most of us. So it's an interesting institutional bias also. Sorry, so I don't have any disclosures that are relevant to this talk, just some committee and editorial board work. So I'm just going to go through kind of what our guidelines are and, you know, to the point that was just made about how we all need to come together. I think in orthopedics, historically, we did not do a great job of looking at trauma, and probably this is because arthroplasty is a little bit easier. I think they've been doing very specific research about their surgeries for a lot longer or in a different way than we have in trauma, just because there's so much more variety. So for a long time, we really relied on these guidelines, which are over 10 years old now, but they were for elective hip and knee arthroplasty, and that was kind of considered the, quote, major surgery in orthopedics. And the guidelines were not excellent, but what they said was major orthopedic surgery, which again was total knee and total hip arthroplasty, and then eventually they added hip fracture surgery, which is a little bit vague, kind of a different patient population, but they basically didn't have any guidelines at all for polytrauma patients, which is what we're interested in. And they said for isolated injuries below the knee, we don't need any prophylaxis rather than pharmacologic thromboprophylaxis in patients with isolated lower leg injuries requiring leg immobilization. So I'm glad, I think it was Dr. Malhotra that said you got Lovenox or something after an ankle fracture, so I'm glad they were doing something for you. But we didn't have great guidelines, so we kind of had to look at other societies. So in 2019, the American Society of Hematology came out with these guidelines, and this was for surgical hospitalized patients. And this is very general, again, anybody who had surgery that was in the hospital. But they said for patients undergoing major surgery in general, the panel made conditional recommendations for mechanical prophylaxis over no prophylaxis, for pneumatic compression prophylaxis over graduated compression stockings, and against IVC filters. And then they went on to say that in patients who are undergoing total hip or total knee arthroplasty, conditional recommendations included using either aspirin or anticoagulants, as well as for a direct oral anticoagulant over low molecular weight heparin. And for major general surgery, the panel suggested pharmacologic over no prophylaxis using low molecular weight or unfractionated heparin. For major trauma surgery, the panel suggested pharmacologic over no prophylaxis. So again, very general, didn't really specifically talk about orthopedic trauma, just some general orthopedic elective procedures as well as general trauma suggestions. So in 2019, this was our Orthopedic Trauma Association Specialty Day, which happens at our annual Orthopedic Academy meeting every year. And they basically came up with a bunch of recommendations based on the literature review that they did. And this was kind of what orthopedic trauma has been going by for the past few years. So they recommend the optimal form of VTE prophylaxis is low molecular weight heparin, as we've discussed in multiple talks here. They actually recommended enoxaparin 30 milligrams sub-Q BID, which again, I think the dosing is a little controversial. We use 40 QHS at our institution for most patients, but they did say that either isolated or polytrauma patients who have musculoskeletal injury should have that started within 24 hours, if no contraindications. So again, always that little tagline that leaves us a lot of questions. The use of unfractionated low-dose heparin, aspirin, and other antiplatelet medications, and warfarin over low molecular weight heparin in the setting of patients with musculoskeletal trauma is not recommended. These agents are recommended over no prophylaxis if their low molecular weight heparin is contraindicated, not available, or prohibitive to the patient due to cost or choice. So this has actually been an issue in our institution. We tried to switch from low molecular weight heparin to a direct oral product that a lot of our patients couldn't afford. So we still have low molecular weight heparin for most patients, but something to think about because obviously many of our trauma patients don't have insurance or other ways to pay for some of these more expensive medications. That was just a moderate recommendation. And then they also talked about different these are all the physical kind of calf pumps and foot pumps and everything like that. In general, they did recommend calf SCDs and low molecular weight heparin together, or calf pneumatic compression devices when low molecular weight heparin is contraindicated. Foot pumps only if patients can't get a calf pump, and then doing initiation of VTE prophylaxis within 24 hours as long as there's no contraindication. The next section talked about IVC filters and other risk factors, as well as prolonged administration of these medications. So this group recommended at least 1 month after discharge for multi-system trauma, including musculoskeletal injuries, but did not recommend chemical prophylaxis in patients with isolated lower extremity fractures and no other risk factors. And they recommended that surgeons discuss prolonged chemoprophylaxis, VTE, in patients with isolated lower extremity fractures and other risk factors. So in this group, an isolated ankle fracture with no other risks would not get medication. The IVC filters, they did have some strong recommendations here. They did not recommend routine screening, as was discussed earlier, and they did not recommend the routine use of IVC filters for low or high-risk patients unless they have a documented DVT or PE already on appropriate prophylaxis. And patients who are thought to be at high risk for VTE with contraindications to anticoagulation should be considered for IVC filter placement. And then the last two, I think everyone here will appreciate. These are both for if patients have other injuries. So while patients with hemodynamically stable solid organ injuries can safely be anticoagulated after 24 hours, provided there's no ongoing blood loss, consultation with the general or trauma care surgeon is recommended. While patients with closed head injuries and stable serial head CT scans can safely be anticoagulated, provided the neurologic exam has not worsened, consultation with the neurosurgeon is recommended. So for both of these, we already know the answer. We're the orthopedic surgeons, but I guess we'll talk to you guys just to make sure. So that was kind of our OTA guidelines that we were going by, and they were really supported by some of the other guidelines that have been around for a while. The chest guidelines also talked about low molecular weight heparin after total hip and total knee, or pneumatic compression devices. This was the same for hip fractures. So again, kind of vague, but not specifically related to orthopedic trauma. And then continuing on the chest guidelines, using low molecular weight heparin in preference to the other agents as alternatives. And then they had one guideline for patients undergoing major orthopedic surgery, which was extending thromboprophylaxis in the outpatient period for up to 35 days rather than only 10 to 14 days. So a little controversial, but we have leaned towards a little bit longer prophylaxis after a hospital stay. The TCLIP guidelines, very vague. There's moderate evidence supporting the use of prophylaxis in the postoperative period, although there's no single regimen that is preferred. And this is the EAST guidelines, which talk about kind of some of the risk factors. Number 3 on the bottom there specifically talks about long bone and pelvic fractures that actually they showed that they were significantly associated with a high risk of VTE in single institution studies, but were not found to be risk factors in their meta-analysis. And then In the Western Trauma Association guidelines, they talk some about isolated orthopedic injuries and direct oral anticoagulants, and they actually said the use of low-dose aspirin may be considered for pharmacologic prophylaxis in trauma patients with isolated orthopedic injuries who decline low molecular weight heparin, and for those trauma patients who are started on a DOAC for pharmacologic prophylaxis, aspirin may replace that after 5 days with similar prevention of VTE. And this is a continuation of that same guideline. This is trauma patients with TBI, orthopedic, or spine injuries, and those who undergo major surgery are at particular VTE risk and should be considered for post-discharge prophylaxis. So again, this recommends longer term, up to 4 weeks after the date of admission prophylaxis. So we know that the patients need something. In general, low molecular weight heparin for bigger injuries from an orthopedic perspective, and we don't love warfarin, which most things I think are showing that's going out of favor anyway, but this is just an example from our annual meeting that showed that patients who come in with a hip fracture who are on warfarin, not for DVT prophylaxis from trauma, but for other reasons, they may predispose to increased blood loss, hematoma, and infection at the time of surgery, but aggressive reversal increases the risk of VTE. So they're a real challenge for us. And the last thing I'll just point out, this is a recent trial, which Dr. O'Toole is here, so he can maybe tell us if there's any new updates on this, but as far as I understand, still an ongoing trial that they're doing actually to look at comparing aspirin versus low molecular weight heparin for blood clot prevention in orthopedic trauma patients. So hopefully we'll have some more answers for that soon. So the last thing I just want to go over, and this is hot off the presses, I don't know if anybody has seen this yet, but was just published March of this year. And this is actually a new consensus conference publication that is over 300 pages that are recommendations from this ICMVTE. So this is 135 international societies from 68 countries and various specialties, including anesthesia, cardiology, hematology, internal medicine, and orthopedics, who analyze the literature in a systematic review format to create practical recommendations related to all subspecialties in orthopedics that would also have global applications. So this was focused on orthopedics, but hopefully could be used more broadly. Nearly 600 experts followed a strict Delphi process, as in prior ICM activities, to generate the monumental document that is available at that link. And I'll just quote from, this is from the editorial comment about this, and it says that many guidelines have limited their scope to a specific surgical procedure, like total hip or knee replacement. Some have failed to recognize the importance of variations in geographic and racial predisposition to VTE, and almost all have attempted to create recommendations by either preferentially or exclusively relying on high-level studies only. While understandable from the methodological perspective, the latter strategy has resulted in the inclusion of studies conducted by the pharmaceutical industry as part of regulatory requirements to have new chemoprophylaxis agents approved for clinical use. Such studies often have been powered to evaluate the difference in the incidence of distal DVT as detected with venography, but not clinically important symptomatic VTE or the rare fatal pulmonary embolus, which is the real concern for both the medical community and patients. Some guidelines have been criticized for overlooking the complications that can arise as a result of administration of some of these agents. So I thought that was just something important to point out about really looking at the literature more single-mindedly. So just to go back 2 slides, this is the general recommendations, which are very, very extensive. They cover evaluation of epidemiology, other risk factors like other medications patients are taking, specific surgical impact like the type of surgery, length of surgery, risk stratification, diagnosis, treatment, and prophylaxis duration. And these are about 160 pages of the total. And then of the rest of the 300 pages, it goes into the orthopedic subspecialties. So the trauma section, which I'm just going to go over here, is more limited, but these are the ones that are specifically related to trauma. So they say that the most optimal VTE prophylaxis in patients with multiple orthopedic injuries is Lovenox, and they specifically state that without equivocation. They say the most optimal VTE prophylaxis in polytrauma patients with fractures and visceral injuries. Once there is evidence that there is no active bleeding, we recommend anticoagulant thromboprophylaxis, generally with weight-based low molecular weight heparin, and generally within 24 hours after injury. For TBI, when consecutive brain imaging is stable for ICB, usually 24 to 36 hours after injury, we recommend starting anticoagulant thromboprophylaxis. And for patients at high risk for bleeding, we recommend starting SCDs. The most optimal VTE prophylaxis in polytrauma patients with fractures and visceral injuries continues to say early fixation of unstable fractures to reduce pain, promote mobility, and decrease VTE risk. So that's something I think we don't talk about enough with VTE is besides all of the treatment for the actual thromboprophylaxis, they need their fracture fixed. If fracture repair will be delayed, we recommend that low molecular weight heparin thromboprophylaxis not be delayed. And I think to somebody's question about where the hot button topics are for the neurosurgical field, I would just put in a plug for the combo neurosurgery ortho patients where we're always vying for when they can start their heparin. Early mobility and daily physiotherapy should also be encouraged. For example, increased risk of DVT was seen after spinal injuries in which spinal precautions persisted beyond 72 hours compared with a shorter time in spite of routine use of SCD in both groups. And then thromboprophylaxis, in this study, they showed that, or they recommended that it generally be limited to the length of the hospital stay. For patients undergoing inpatient rehabilitation, we recommend continuation of thromboprophylaxis with either a DOAC, such as rivaroxaban, or with low molecular weight heparin, and standardized VTE prophylaxis policies embedded in routine order sets, as well as periodic audits of adherence. So making sure the patients are actually getting them. They also stated the optimal management of patients on anticoagulation presenting with extremity trauma needing surgery should involve a risk-benefit assessment weighing the risk of bleeding against the risk of thrombosis. And concerning VTE risk, which surgeries can be considered major and which can be considered non-major. Surgical procedures in the upper extremity and distal to the ankle can be considered non-major. The risk of VTE increases in the lower limb from the distal leg to the pelvis with higher risk associated with more proximal surgeries. In addition to the location of surgery, length of surgery, and expected postoperative mobility must be considered. Is routine prophylaxis indicated with isolated lower extremity fractures that are non-op or casted? No, and the duration of immobilization does not influence it. And then finally, there's a recent push towards Wallant, which is wide awake local anesthesia with no tourniquet for usually hand and foot injuries. And does that have an increased risk of VTE events? They said when that is used, the risk of VTE compared to other techniques is unknown, but they recommend using anticoagulant prophylaxis as per existing thromboprophylaxis guidelines. So in summary, I think that we, again, as many other people have said, still need a lot more research in the area of orthopedic trauma. As you guys know, over half of our patients in trauma have orthopedic injuries, so I think this is really important, but we do recommend low molecular weight heparin for most patients and starting as soon as possible. I'm happy to take any questions. Yes.
Questions for Dr. Miller? Yep. I have a and a question. Comment is, or the request is that if you would please introduce yourself when you're asking a question so that the folks watching on Zoom will know who's speaking. That'd be helpful. The question is from Lawrence Lautenberg. Why do orthopedic surgeons almost always want Lovenox stopped prior to operative interventions and therefore interrupt prophylaxis?
It's a great question. I don't know the answer to that. We don't ever stop Lovenox at our institution. We, partly because of our protocol, we give 40 QHS, as I mentioned, so every patient gets Lovenox every night. And they don't get a morning dose because they already got their evening dose the night before. There is no morning dose, so perhaps it's an institutional issue of not giving a morning dose. I think a lot of orthopedic surgeons who use regional anesthesia a lot, their regional anesthesia providers may be talking to them about not giving certain doses, but I think really a lot of it is historic, and like many other fields, we just need more education for people to understand that they can operate even with slightly higher INRs or having a DOAC or a low molecular weight heparin on board.
Costantini, San Diego, great talk, thank you. I want to just get your thoughts on post-discharge prophylaxis. You know, in our institution, our ortho trauma partner has been great. We don't hold Lovenox for any reason, for anything anymore, which has been great. But I'm seeing more and more expanding indications to send people out on 4 weeks of Lovenox, 2 weeks of Lovenox, 4 weeks of aspirin. I can't really make heads or tails of how it gets selected and where that data is coming from. And so I'm just interested to hear how you manage it and maybe what you're talking about at your orthopedic trauma meetings.
Thank you. So the guidelines, I didn't go into the entire 160 pages of the general guidelines, but that section does try to answer that question of post-discharge prophylaxis for major orthopedic procedures, which includes trauma and total hips and total knees, as I mentioned, but they do recommend 35 days. So I don't know the original, and I'd have to go back and look at the reference of where that comes from, but that is the most recent recommendation in that guideline. So which medication, I don't know if it's a non-operative fracture or a minor orthopedic procedure. They probably don't need any as recommended in that trauma section, but for major procedures, they are recommending that month after discharge.
Hey, Eric Lay here. Terrific talk. I think you provide another example of somebody who's within the trauma field who should be involved with future expert guidelines to provide so we can continue to improve. There was an area that one of my orthopedic trauma partners brought up that I wonder if you could comment on, that she doesn't feel comfortable with prophylaxis around joint surgery due to the potential and the related morbidity. Is this something that we should focus on in future editions of our guidelines, or is this something that it might be just isolated? How do you feel about prophylaxis around joints?
So I assume, do you mean total joint replacement, or do you mean joint fractures?
Thank you. Actually, the answer is both, but I imagine it's probably more around the latter.
Okay. So, you know, one of the things that I think we need more literature on that specific topic, because they've done a lot of research on total joint replacements, but not a lot on periarticular fractures regarding the postoperative bleeding risk. But one of the things that I actually had some slides, but I hid them, that we're really doing more and more of is using TXA, and that may be an area where we could kind of do more evaluation to whether that can help with bleeding risk and also allow us to have VTE prophylaxis and not worry about the bleeding risk as much. But I don't know how widespread that thought is in the orthopedic community, but in general, I think that's less of an issue in periarticular fracture. Like, we don't really discuss that as much at trauma meetings as they do. They do worry a lot about bleeding in the joint after arthroplasty, because then they get arthrofibrosis, a lot of stiffness, and we kind of think they may get that, but they also have the stiffness from the trauma itself, so it's hard to delineate versus an elective total joint where you know they could move their knee before and now they've bled into their knee and they can't move anymore after they came in for you to make them feel better. So certainly I think it's a big issue that the total joints people talk about. But yes, I definitely think that would be a helpful guideline to have.
Other questions for Dr. Miller?
All right, thank you.